Good afternoon, everyone. Let me just check my IT here. All right, good afternoon, everyone. Welcome to the Support Hospital Opioid Use Disorder Treatment. That's SHOUT, Texas Echo. Note, you should have just gotten a notification. We're recording these sessions and we'll make them available later. Know that your names do not appear on the recording, nor does anything else that you list in the chat. Thanks to all of you who are joining us today. I see a few more joining in too. Just a few quick announcements before we begin. My name is Andrea Roche. I'm with UT Health San Antonio Echo. I'll be facilitating our conversation today. But to help us with attendance, please enter your name, your affiliation, and your email into the chat function. We appreciate your help. This is just with our own record keeping of attendance. We do love to see everyone's smiling faces. So if you are comfortable and able, we encourage you to join by video, especially for the discussion portion of the session. We encourage everyone to speak today, but do ask that you stay muted unless you are speaking. You can also communicate, raise questions, share your own experiences and challenges using the chat feature. But just know that no protected health information is allowed at any time during the session, either in the chat or during our discussion. I mentioned earlier that we are recording these sessions and we'll make them available on the Texas Mood YouTube page after the session. During and after the session, the Shout Texas Echo team is also going to send you a link to an evaluation. We do ask that you fill out that link. It's how you can get CE if you're interested in that for today's session, but it also helps us to structure and frame future work from this program. Our didactic today is about delivering high value care for substance use disorder in the hospital setting. And following that, we're going to discuss a case from Baylor Scott & White Health. So we're going to start with some introductions of our team, followed by those didactics, announcements from the Texas Mood program, and then the case presentation. And then that leads into the best part of the session, which is that open discussion with all of you. So with that, let's start with some introductions of our hub team. Rich, we'll go with you first.
Hi, I'm Rich. I'm a physician assistant at Dell Medical School and lead our hospital substance use disorder work, and excited to be here.
Thank you, Rich. And Chris.
Right, Chris Morades, hospitalist, part of the Shout Texas team, and we'll be presenting today about high value care.
Thank you so much for joining. And to our case presenter, Ada.
Good afternoon, colleagues. I'm Ada Sapp. I'm a psychiatric mental health nurse practitioner in community mental health practice here at Baylor Scott & White Health Memorial Temple.
Thank you for joining us. And I see, Blair, you've also joined us. Oh, can you unmute?
Sorry. Hi, I'm Blair Walker. I'm with psychiatry at Dell Seton Medical Center. And the consultation liaison psychiatry service line lead for Ascension Seton, and part of the B team here. Work with Chris and Rich.
Thank you so much. And you know what? We have an intimate enough room today. I'm going to ask everyone to introduce themselves. So I'm going to prompt you one by one as I see you on my Hollywood squares. Just let us know where you're calling in from. Starting with Elena.
Hello, hi, my name is Elena Jimenez. I'm a hospitalist from internal medicine hospitalist from UT Health San Antonio.
Thank you. Kimberly. Kimberly Brooke, can you unmute? Oh, there we go. She's entering info in the chat. Thank you, Kimberly. Grace. Grace Diaz, can you unmute and introduce yourself?
Good morning. I'm Grace Diaz with MedMark El Paso.
Thank you. And Sharon's iPhone.
Did you hear me?
Now we can hear you.
Okay. I'm Sharon Schumacher, Reentry Peer Specialist with Abilene Recovery Council.
Thanks for joining us. I see Veronica.
Hello, everybody. I'm Veronica Perez, an addiction psychiatrist at Baylor Scott & White in Temple, Texas.
Thanks for joining us. I see a Ditar Family Medicine, I believe.
Hello, I'm Daniel. One of the third-year family medicine residents down here at Ditar in Victoria, Texas.
Thanks for joining. William.
Hi, I'm William Thomas from Emergence Health Network, El Paso, Texas. I am the OBOT supervisor with a couple other programs as well. Good to
Thank
see you guys.
William. Thanks for joining. Cindy.
Thank you.
I am Cindy Dinsmore. I am with the PPI program here in Tarrant County with John Peter Smith Hospital.
Thank you for joining. Emily Ibarra.
Hi, my name is Emily Ibarra. I work at Bentop Hospital in Houston, Texas. I work with our maternal substance use program, nursing program manager. Thank you.
Thank you. Dustin.
Hi, I'm Dustin DeMoss. I'm the medical director for Trinity Springs Pavilion Hospital in Fort Worth as part of JPS, and am a grantee for the Shout Grant, and happy to be here.
Thank you. Susanna.
Hi, I'm Susana Del Toro, and I represent Houston Recovery Center in Houston, and I am the Director of Programs and Services.
Thank you. Lindsay Welch.
Hi, I'm Lindsay Welch. I'm a medicine hospitalist at University Hospital with UT Health, a colleague of Elena. Happy to be here.
Thank you. And Rhoda.
Hi guys, my name is Rhoda Hall. I'm with Primary Care. I'm a PAC counselor for OBOT as well, and I'm in Odessa and Midland with Primary Care.
Thank you. Kimberly Brook. Kimberly, can you unmute and introduce? That's all right. We'll look to the chat. Paula Shireman.
Hi, I'm Paula Shireman from the University of Texas Health Science Center in San Antonio.
Thank you for joining us. I see a Snehal Patel.
Hey everyone, Snehal Patel, I'm an internal medicine hospitalist at Del Med in Austin.
Great. And a Stephanie.
Hi, everyone. My name is Stephanie. I'm a licensed chemical dependency counselor and a peer recovery navigator with Parkland Hospital.
Thank you so much. What a wonderful group of people. Thanks for working so quickly through those intros. It's great to hear all those voices, see all those faces. Well, at this time, I'm going to turn things over to Chris, who's going to take us through our didactics for the day. If I did miss you, please do feel free to use the chat and introduce yourself. We're glad you're in this space with us. Chris, when you're ready, take it away.
Great, thank you. Hi, everybody. As mentioned, I'm Chris Morides from Del Med and from our Shout Texas team, our B team. And I'm going to talk today about high value care. And it's going to be more, over the next 15 minutes, primer around high value care in general, but we'll work on applying it to substance use disorder, particularly for hospitalized patients. So I do not have any relevant disclosures for this talk. And here are our objectives. So because some of you, in order to get us all on the same page, I'm first going to concentrate on defining value in healthcare and reflecting a little bit together on outcomes that matter for people with SUD. And at the end, I would like us to identify opportunities to improve value. And my goal, I know a lot of times with these parts of the didactics, it's more delivered, but I would appreciate if this can be interactive. So I'm looking forward to your comments and suggestions, either unmuted or through the chat box, which I'm able to monitor throughout. So oftentimes start with this story. So this is Bob Wachter. He was my old boss. He's like a well-known national leader in hospital medicine and health policy. And years ago, I was talking to Bob, and he told me that he was in a small seminar, much like this one probably, but it was in the pre-time, so it was live, and with a bunch of students. And the students were asking, what would be so different about their careers compared to the career that Bob had had. And so Bob was thinking back over the last few decades of his career, and he thought, Chris, what a great opportunity to shake them out of their youthful complacency. So he said, I started to tell them, you folks, you need to be prepared for a career that'll be massively different from mine. You will be under relentless pressure to deliver the highest quality, safest, most satisfying care. He says he spoke the word slowly with gravitas, all at the lowest possible cost. You let it sink in. And you're under relentless pressure. We all know this. We feel this pressure. And one of the students raised their hand and they said, Dr. Wachter, what exactly were you trying to do? which is both incredibly brilliant and naive at the same time, right? Of course, that's what we're here to do, especially those of us who are hospitalists and work in the hospital. Like, our whole reason for being is to deliver the highest quality, safest, most satisfying care at the lowest possible cost. But it's not really what we've been thinking. Now, to be fair, over the last few decades, our capabilities have advanced tremendously. So the breakthroughs, the pace of breakthroughs, I think have been breathtaking. I mean, we can cure hepatitis C. We couldn't do that a short time ago when I graduated residency. We have more things in our armamentarium. We have actual personalized, therapies for certain cancers, so on and so forth, things that we only dreamed about. And yet, even though we have these theoretical capabilities, when I ask people, well, how much does that cost anyways? And how are we going to make sure that we can deliver it to the people who actually need it, right? So we can cure Hep C, but it's $1,000 a pill. How do we ensure that we get it to the folks that need it? Usually get the same response, which is like, I don't know, not my job, not sure. But I'm here to say, I think there's a better way. We can do better, because this is clearly important to our patients. And the way to do better, the framework, I believe, is a framework of value. So those of you who have heard of value before in the context of healthcare may have different definitions for what that means. You can see it defined as quality and safety over cost, quality, safety, and experience over cost. All that I think is fine. At Del Med, we went back to kind of the original definition in healthcare, which is to say that value is outcomes that matter to patients over total cost of care. One of the reasons for that is because quality is an input, and it's a little hard to define, like, what really do we mean when we say quality, but outcomes are clear. That's the goal. That's what people come to healthcare for, is to get better, to achieve outcomes. So outcomes that matter to patients over total cost of care. If one thing comes out of this talk, I don't want anybody here listening to me to ever have the misconception again that value is code word for cheap. Nobody wants cheap healthcare. I don't want cheap healthcare. Your patients don't want cheap healthcare. But that oftentimes it gets this rap. People hear value and they're like, oh, that's just cost cutting. That's just cheap. No, value is simply saying, is it worth it? And the answer to is it worth it is almost always, it depends, right? Is an MRI high value? Well, am I using it to rule out an epidural abscess in a patient who uses IV drugs? Super high value test. Am I using it for routine back pain in my outpatient? Super low value test. Even though it costs the exact same, it's whether or not it gets the outcomes that matter. So keeping that definition in mind, a question that oftentimes comes up is, what do you mean outcomes that matter? Don't outcomes matter? And this, I think, is a key part for us to understanding what it means to improve value in healthcare, particularly for those patients with substance use disorder. So can any of you all, you can go ahead and use the chat box or feel free to unmute. Can you think of measures in healthcare that don't actually matter? Things that we pay a lot of attention to, a lot of effort, but don't matter to patients. You guys don't go to the same meetings I go to where they just march up all the metrics that I'm responsible for all the time? You don't sit in those meetings where they say, hey, your length of stay is up. And I say, oh yeah. Yeah, discharges by 11, love it, early discharges. So, we can think of a bunch. I mean, even we can start to say, like, is hemoglobin A1C the measure that actually matters? Yeah, lipid panel numbers, is that actually what matters? There's a lot of these measures, these process measures, these surrogate markers. They might be important, but are those the things that truly matter? So as a hospitalist, I'm going to focus on my favorite one, which is length of stay. When I first got here, our chair, Mike Pignoni, was like, Chris, I want you to chair the length of stay committee. And I was like, that sucks. Because, should we decrease length of stay? Yes, of course. That's why, hospitalists exist, because we're supposed to deliver care more efficiently, more effectively. And indeed we have. So if you look at this data, which now is getting a little old, but from 2004 to 2011, on a national level, hospital length of stay, the first bar, decreased significantly. It's hard to move the needle nationally, and that happened. So hospital length of stay went down. What do? we actually shifted more and more patients to post-acute care facilities. We sent them to SNFs, we sent them to LTACs, we sent them to rehabs. And so in fact, if you measure total length of stay, meaning combining hospital and post-acute care, total length of stay went up. What happened to cost, by the way? Even though the patients were in the hospital a shorter amount of time, we charged more and we did things more efficiently, more quickly. So actually costs went up in the hospital, costs went up in post-acute care, costs went up in total. And so my question for you all is length of stay important? Yes. Is that the measure that actually matters? Does our patient care if we take them from a hospital and we put them in an LTAC that looks all the world like a hospital? Or if we take them from a hospital and we put them into a SNF, where not only does it feel like a hospital, but they're not even maybe getting the level of care that they need for their wounds, for their IV antibiotics, so on and so forth? No. So what can we do? Well, these authors in the New England Journal in 2017 who presented that data said, if we want to measure what matters, we should talk about things like home-to-home time, the time a person left their home to the time they went back home. And here's the thing about home-to-home time and why I bring it up, because if that's the outcome that matters, and that's the outcome that we started to hold ourselves responsible for, it shifts how we deliver care. Because suddenly my hospital would be responsible for making sure that we're truly coordinating with the post-acute care facilities, and that the post-acute care facilities are truly doing what's right by the patient and discharging them as soon as it's safe and appropriate to discharge them, rather than, oh, look, their insurance approved 28 days. They needed exactly 28 days. It's amazing how that always happens. So it changes the way we coordinate, changes the way we deliver care. It also means that if the best place for my patient is to finish their IV antibiotics in the hospital, I don't have that pressure to just ship them to a SNF to finish their IV antibiotics, because we're measuring home-to-home time. And that's the care that we're responsible for. Rich and others, I think, have participated in this American Hospital Association group that are working on defining some of these different measurement outcomes that we could apply specifically to opioid use disorder. And there's a number of them in there under different conditions, but here is just a list of proposed measurements for identification and treatment of opioid use disorder. Why don't we start measuring, whether your hospital, the number of referrals for treatment, how many patients you started on treatment? Maybe those are measures. Not that length of stay doesn't matter, but like, shouldn't we also be measuring these things and paying attention to them? The ACP has a 5-step framework to promoting high-value care. 1, all of us in healthcare should understand the benefits, harms, and relative costs of the intervention we're recommending. The fact that that seems unlikely, I think, says a lot. The fact that we think that, oh, well, of course, I don't understand all the relative costs of the intervention that I'm recommending tells us a lot. We should decrease or eliminate interventions that provide no benefit or might be harmful. We should choose interventions and care settings to maximize the benefits, minimize the harms, and reduce costs. We should customize care plans that incorporate patient values and concerns, and we should complete a bias check-in. So their thing is, if we're customizing plans, we should ensure that that's not increasing disparities and bias. And we should identify system-level opportunities to improve outcomes. One way to do this is to cut out waste. So one way to do this is to stop doing the things that we do for no reason, the things that don't make people healthier. Anybody know or want to take a guess on how much of healthcare that we deliver is estimated to be wasteful? In other words, does not make people healthier, which causes, by the way, both physical and financial harm. Anytime we intervene on someone and it doesn't make them healthier, we are liable to create physical and financial harm. Luckily, it's not 1 out of every 2 things I do, but that's not a bad guess. It's not 50% of my world, but it is. I'll move on because I know we've got limited time. It is about 1/3. Yeah, Kimberly, it is about 1/3 they've estimated of care delivery is waste. There's different buckets for this, don't commit fraud. Good, check. The fact that our prices are excessively too high, that an MRI costs a lot more here than it costs in France. It's the same exact machine. That's a problem. Inefficient care due to system errors. We see that every day, all day. Unnecessary services, so stuff we do that are not helpful. Good question, Blair. The answer is this data comes from the US. I will tell you, I don't know comparatively if it's a third in these other countries, but choosing wisely, which I'm about to talk about, is international and actually has been just as relevant in places like France and Switzerland and elsewhere, because there's overuse there too. Or even if you want to look in the US, think about how much overuse is within our VA systems. And our VA systems don't have fee for service. They don't have the same type of malpractice concerns. And so you can tell that that's an issue. All right, so lastly, and I think I've got it, so we started at 12:08, so I think I've got to 12:22, but I'm gonna run right to that and we won't go over. Can you think of opportunities to improve value for hospitalized patients with SUD? Specific areas of overuse and underuse. Feel free to unmute or use the chat box. I don't know what they are yet. We're working on defining those, I think, together. And I really am interested. I'm hoping that this talk just gets those wheels spinning for you. But certainly underuse, yeah, of evidence-based medications. I mean, the fact that we underuse buprenorphine, the fact that we don't treat is a big one. I think, there's question, I question whether we overuse drug screening. I think we probably do. I know that that can be controversial, but like our patients tell us what they used and then we send a urine drug screen on them. That always blows my mind. Like the patient says, I'm here with chest pain and I took cocaine, and then we're like, send their urine. So I think there's a lot of overuse around drug screening and it's expensive. So we can identify some of those. All right, hopefully I whet your appetite around high value care and thinking about it. If you want to learn more, Choosing Wisely is a national campaign. You can go to choosingwisely.org and you can find list of things that patients and physicians should question. In other words, these areas of overuse. I think there's a big opportunity for the substance use disorder community, because there is although there's over 75 lists, there are none at the moment, specifically from one of the substance use disorder professional organizations. And I have a freely available tool for you. So our Discovering Value-Based Healthcare modules, they provide free CME. These numbers actually were pre-COVID, so I think could be updated quite a bit. But people are using it across the country, and they provide, like I said, free CME, CNE, and they teach you about high-value care. So it's VBHC. I'll put the link in the chat box. All right, so we're up at 15 minutes here. If I think we can maybe discuss this, or at least use this framing as we move forward. But I certainly welcome further conversation around it, and you can contact me at email, you can tweet at me, and we can talk about this publicly, whatever works for you. But I've been thinking more and more, like I said, around this intersection of high value care and substance use disorder. And I think it's pretty clear that as a medical profession, high value care is where we want to go. And I think those of us who've treated patients with substance use disorder are used to the framework of meeting people where they are. So I've been thinking about this as meeting people where they are and getting to where we want to be. And I think that high value care is a great framework for us to do that. We can meet at that intersection. So thank you. I'm going to go ahead and pass it on.
Chris, terrific presentation. Thank you, and a lot to think about. Any questions for Chris? There is one in the chat from earlier from Blair, and I think it was in context of actions creating waste. Is that just in the US and better in socialized medicine like France, Switzerland?
Yeah, I think, as I was saying, I'm not, I don't know the exact like relative numbers there, but overuse is actually very common even in countries with socialized medicine, even countries that are not fee for service. And there's been reports that have been published in BMJ, where some of the big reports showing the degree of overuse around the world.
Other questions? All right, if they do come up, please feel free to drop them in the chat or unmute. We always like that, and it may even dovetail with our discussion today. I just want to share some updates from the Texas Mood program. Echo IT, if you could go on and begin sharing those slides. So as you may know, Texas Mood, I'll just start talking while you're sharing. It's the largest training and technical assistance center focusing on substance use disorder in Texas, acting as a one-stop shop for those working in addiction treatment and recovery services. Just in time for me to say next slide. So Texas Mood offers education, training, resources, and research for the substance use disorder workforce, with clinical services focusing on expanding access to treatment and recovery services for the uninsured, telementoring efforts to expand the treatment workforce and their skills in Texas, and then also research to support cutting edge treatments and their dissemination. Next slide. Specifically, Shout Texas is a program at Del Med School at the University of Texas at Austin and UT Health San Antonio's Texas Mood team, working to increase access to substance and opioid use disorder treatment and harm reduction during acute hospitalization. So Shout's mission here is to expand this proven model of hospital-based treatment for opioid use disorder to all hospitals in the state of Texas through education and coaching opportunities. That includes those things you see at the bottom there, the monthly ECHO series. Hey, welcome. Monthly general office hours, bi-monthly OB focused office hours, and then expansion of a pilot program, including up to $35,000 in seed funding to start similar programs in hospitals across the state. Next slide. Speaking of echoes, we hope you join us at the next one, Thursday, November 18th, and you can see here the details for that. And next slide. And there's also an upcoming buprenorphine DEAX waiver training in December, and note that these are available upon request and can be individualized. Next slide. So Texas Mood is announcing its Heroes Helpline. It's available to all first responders and healthcare workers, including allied health professionals in Texas. It's free and provides confidential telephone-based peer support and referral services to all first responders and healthcare workers in Texas. So just go to heroeshelpline.org for a little bit more information on that. Next slide. And just to keep you updated, sign up for all of the Shout Texas educational opportunities at their website. That's shouttexas.org. I'll put that over in the chat though. The next round of pilot seed funding is going to be opening up and available on a rolling basis starting soon. So if you're interested, if your organization is interested, email the Shout team to get connected. Again, we'll put that information over in the chat. Next slide. And this is just part of the effort to keep revising and providing services that respond to the priorities and assets of our learning community. So give us some feedback on how these sessions are going. We're also going to post this link in the chat a little bit later, post an evaluation link in the chat a little bit later. So thank you so much. We're going to stop the screen share now. And we're going to turn things over to Ada, who's going to take us through our case presentation and sort of systems discussion for today. So Echo IT, if you could go on and pull up that case form. All right, Ada, tell us a little bit more about, we kind of have an exemplar client and then we have a larger discussion to have here. So if you can go on and begin your presentation.
Thank you, Andrea. Good afternoon, colleagues. I'm so glad to have been asked to do this today. I'm really excited. I work with Dr. Veronica Perez here at Baylor Scott and White Health. We're at the Temple Medical Center, and we wanted to particularly focus on nursing today. We're in our infancy, having been awarded a Shout grant and have had some significant important time both visiting with Rich, Alana, and also a summertime meeting in Austin with our colleagues at John Peter Smith, and those are all really helpful and instrumental. This is really for me more of a systems approach. I did put that Dr. Perez and I have shared a patient who was recently in our clinic with buprenorphine treatment and doing quite nicely, who necessitated, because of her life concerns, major surgery. That got us up close and personal with a team of her care providers. And so she's really kind of the direction of this from a system standpoint, since we are trying to this month start our SHOUT grant focus on patients who come to Memorial with high recidivism, endocarditis, other soft tissue injury, cellulitis, et cetera. So I really wanted to kind of open up the discussion today about some of y'all's successes with the SHOUT grant and program. I was really interested in zeroing in on nursing pearls of wisdom and lessons learned in implementation, since that's what we're really focused upon right now, and other discipline related pearls, because it takes a village. It obviously takes a team to really make this happen and make it successful within a medical complex. My heritage really is about being a nurse generalist. I'm a psychiatric mental health nurse practitioner, but I also am a marriage and family therapist and an adult clin nurse spec. I've coming up on my 42nd year of practice from BSN to now, done a lot of work in academia and community mental health through the years in part-time private practice. But my ideal always is, how can nurses be in the best position to start planning for discharge at the moment of admission? And how can nurses be instrumental in making that very seamless? And so that's really my frame and where I'm coming from here. So a transition to facilitate patient recovery, support, et cetera, and a re-entry into care in the community. So what have been your lessons learned in equipping nursing professionals to educate and encourage patients regarding MAT? Nurses are the pinnacle of care on a team, especially in the hospital, since we are at the bedside so much, and develop relationships with our patients, and especially in the recidivism concern, really focused on that area. How might we as a profession be more empowered to influence and advocate for patients within our healthcare team? We've had some real successes so far with supportive nursing leadership, professional staff development colleagues. Ours happens to be one of my former students and a real amazing psychiatric mental health nurse, although she's kind of like me, has done a lot of different things in nursing and is very much a generalist. In meeting with our Baylor colleagues in Dallas, the other thing that we really want to focus on is QI, which dovetails nicely into Chris's presentation today about value and really being on top of those concerns. We are really working to tailor make our education, teaching, learning strategies. We've got a host of nursing units, and we don't know always where our patients may end up. We've got practice alerts, ongoing education and support, and we have fairly recently become magnet designated. So that's been with Alana and Rich's encouragement, another part of our foci. We've had some obstacles, as you can see there. One of the things I've learned up close and personal is it matters, third-party payer and insurers. Because sometimes insurance coverage looks different from hospital to community mental health and all outpatient status. We're no different from anyone else with stigma and barriers to care, language, those kinds of things. How, again, can we best educate and help people use MAT to its very finest on behalf of the patient? So that's kind of where we are right now, and I am willing to listen and give reflection and feedback, and whatever. I'm open to whatever y'all have discipline-wide to focus on nursing today. Thanks.
Thank you, Ida. That was awesome, and we greatly appreciate your insight as a nurse and really raising this important series of questions. The way, if I can kind of just distill it into one sentence, which is hard to do because you brought up so many impactful things. But just as a starting point for the group, what I'm kind of distilling from your questions and your comments is, nurses are important. They're really, really, really important in the team, in the care team, the overall interprofessional team, in caring for hospitalized patients with substance use disorder. So maybe we can start with kind of just a broad question for the group here, which is, how do we empower? How do we empower nurses who are at the bedside with our patients for 12-hour shifts, 8-hour shifts? How do we empower nurses to deliver better care for people with SUD in the hospital? What are some suggestions?
Hi, this is Emily in Houston at Bentop, nurse here. And that's a really good question. And it sounds like obvious, like, hello, nurses are so integrated in care and we should just catch on and be ready. But that's definitely not the case. I will definitely say that, in my whole hospital, I'm definitely like the nurse champion. There's just one with my population, pregnant women. But one of the really cool things that we did this summer, which I think has helped, illuminate the nursing mind, is we launched universal substance use screening using a standardized tool, not UDS, to Dr. Moriarty's point about overuse of UDS for screening for substance use disorder. And I think that kind of just made it less scary for nurses. I think, and I know many are like, why is this scary? And it's just because they're not exposed or even know what tools they have. They have the tools, but they just don't know how to utilize them when working with these patients. And I think that just really opened doors. So we launched it in all of our prenatal clinics in the system. And again, if like standardizing these screening tools and the conversations, I think has really helped. And we gave the role in the workflow of clinic was screen, and then if they screen high risk for substance use disorder, then the provider can have the discussion. And then if needed for treatment, they can come to our clinic. But I think just opening that conversation at a system level was really helpful. And then we had to do inpatient education in parallel to that. The inpatient team was actually much more open to doing screening when patients arrive, because they're just used to sick patients. So I think that has gone overall well. And I think when they know someone that they can ask questions to, that's helped too, because honestly, there's just not a lot of awareness about medicines for opioid use disorder and that there is treatment. And even things like we had a patient who was waiting for a tubal on methadone, and she was NPO and very uncomfortable. And the nurse didn't think, oh, I should advocate for my patient. She can take her methadone while she's waiting for this procedure, so she's comfortable. Like little big things like that, and having those discussions and looking back and now proactively saying, these are what these patients are going to need when they come in. And so that's been successful so far. Again, we still have many holes to close, but that's one thing we've done.
Thanks, Emily. That's wonderful. I heard three sort of main themes there. One was trying to incorporate standardization, especially around screening, and that can help empower nurses. Two, developing some sort of mentorship relationship, or at least kind of an expert network relationship where people can ask questions. And then three, really empowering nurses to be advocates. And I'll just say, if I had to, I hate to do this, but if I had to pick one profession in healthcare who's like the best advocates for patients, it's nurses, right? And so how do we advocate for them to have that role around advocacy, specifically around substance use disorders? So awesome. Thanks so much, Emily. It's really great. Other thoughts from the group? One item that I might share, I see that there's a comment in the chat here. Yeah, education, absolutely. Education and support. One of the things that caught my eye, a lot caught my eye in your presentation, Ida, but one of them was about Magnet. And when I reflect on our work at Del Seton in Austin, we just received our Magnet designation as well. And when the reviewer was reading through everything from their review from the group, they identified our work around opioid use disorder as a exemplar practice, meaning a practice that basically any other Magnet site or Magnet applicant should try and emulate, which is not a pat on the back to us. I think it speaks to the importance of the nurse role in this. And it was really wonderful for our nurses to be recognized for their many contributions to our program at Dell. So the question I have for the group around this is, what are other ways? I mean, Magnet is obviously kind of one of the pinnacles for nursing, and that there are many nuances there and expenses and whatnot. What are other ways that we can recognize nursing and elevate nursing? Kind of going back to that empowerment question. What are ways that we can recognize nurses as champions for addiction care in hospitals?
That is such a good question. And it's a tough one. I think that partnering, and I am curious, did you guys have, and I'm sorry if I should know this, but did you guys have a nurse champion on your B team? Do you guys have one at Austin?
We do.
What is his or her role?
So the role has evolved over time, which is also something I think the group should sort of think about. It's had some flexibility. So when we first started, there was a large learning curve for nurses on even the COWS assessment, you know, sort of comparing COWS to CWAH for alcohol withdrawal. And I don't want to say large learning curve in a way that scares people away from this, but there was some education that needed to happen, and it very much. We often talk about kind of see one, do one, teach one in medicine. I think this was very much the same for nursing, that once a nurse did it once, they were like, oh, this isn't so hard. This is very straightforward. And then they went forth and they showed someone else how to do it. So it was our nursing champion's role to sort of get the ball rolling on the different nursing units, to go to some of those department huddles, those pre-shift huddles, and sort of talk about this. And really just to be a resource. As a PA myself, or my physician colleagues, or our pharmacy colleagues, it's just different when you're talking to someone who is your profession. So to have a nurse speaking to nurses is just really helpful.
Yeah. And again, I'm thinking again from a maternal health perspective, because that's what we do at our hospital. But the other way we've integrated it into our program is maternal levels of care. As far as like a kind of recognition based, it's not strictly nursing, but it is a whole program for our specialty that we've packaged up, that we have a perinatal substance use program when we're talking about our program and getting the education out. So I think that's been a way for us to integrate it into nursing as well, is because people know we have the program now. We have to teach others about it, including lower level hospitals. And it also includes our neonatal program because of, you know, neonatal exposure and alcohol, not alcohol, withdrawal syndrome. So we also had an integrated program with Eat, Sleep, Console at our hospital. So that program, again, spanning more than just OB and touching neonatology, that also engaged nursing as well. So just another concept.
Yeah, absolutely. There's this organizational change, I don't call it a principle or whatnot, but you know, snowballing. You know, it starts out small. The more people that learn about it, it grows and grows and grows, and it starts to sort of take on a life of its own. I think nursing is certainly, you know, a critical part of that. I want to just draw your attention to Snehal Patel put a comment in the chat, and Snehal, if you're able to come off mute and expand on this a little bit, that would be awesome. But he put that, you know, nursing champions advocacy can shift the culture within the hospital, and I really want to recognize that this is, as much as it is a a quality improvement initiative or an effort that we're doing at the bedside for individual patients, it's also this organizational culture shift of how do we think about SUD care in hospitals as a whole? How do we deliver whole person care that includes the SUD? And again, in the context of today's conversation, empowering nurses to be critical role and team members in that. Snehal, are you able to come off mute and just speak to that for a minute?
Yeah, no, I mean, just as you said, Rich, right? Like, I think creating a culture where nurses are empowered to advocate for their patients, and that advocacy can then really lead to culture change amongst other providers within the health system, within the hospital. I think it does require, I think historically, and this is not just for nurses, but social workers and physicians and providers in many different professional categorizations, right? A lot of times advocacy is shut down at an institutional level. And so how do you push past that to support those who are advocating on the front line? And if you can get to a point where that then leads to a greater cultural, some level of momentum to support that, you could potentially lead to, create culture shift within the institution, right? I would say that's certainly true here as well, right? Like a few years ago, the culture was different than it is now when it comes to advocating for individual patients to be able to get the medications that they need, at the moment that they need them. Yeah.
Thanks, Snehal. One of the things I took away from your comment was that piece about that sometimes advocacy can get sort of shut down, or it's hard to navigate at the institutional level, which I also think brings into the mix sort of this executive level support and some of the push-pull that can exist between the frontline and people who are at more of the executive level. And so one of the things that I would add, and would love to hear a comment or two from the audience, is around sort of burnout. And burnout's a big topic today. I certainly think COVID has exacerbated burnout amongst healthcare workers, in particular ones who work in the hospital. And we often hear about and read about and experience burnout related to working with people who have SUD. My personal take on that is a big part of it is not having the tools in our tool belt to appropriately address this patient population. And Ida mentioned this, or it may have been Emily, I'm sorry, that sort of giving people the ability to do the work. And actually it was Emily around screening, for example. So giving them the tools that are standardized to say, this is something that you can do for patients with SUD. This is a way that you can positively impact care, may actually go a long way in empowering folks because they feel like they're doing something positive and potentially could reduce burnout. I don't know that this has been studied in the hospital addiction care world, but I think it makes sense, and I think can be part of how we share it with administration or get administrators on board. That was certainly the case for us with our chief nursing officer. But does that resonate with others? Is that an approach that others have considered using?
I wonder, just Rich, and maybe tagging off of that a little bit, Chris, if you could sort of share your perspective from the value-based approach. I think there's some themes in your didactic that align with what we're talking about here with integration of more disciplines in the care team. That's more people, right? That's more people spending more time. But is there an argument to be made here?
Well, I think, yeah, for sure. I mean, particularly in addiction care, in many areas of healthcare, but in addiction care, team-based care has been shown to be more efficacious, actually. And so creating team-based care models, and once again, the way we define a team can vary. I mean, we're focused in right now in the hospital, but certainly a big part of what we've done with the B team was about the handoffs, enlarging our team to include the the FQHC that we send patients to, and creating that sense of team amongst ourselves. And so that can be really important. One thing I've been struggling with, which I don't know if it fits in this conversation so much, but it's definitely on my mind, is as we shift to more team-based care, one risk that I've seen is a diffusion of accountability that can occur. And so that's something I struggle with, and I just put that out there. But you know, how do we still stay accountable to the patient, particularly in the hospital, when you now have a team-based or in a shift-based model, and we're handing off, and everybody's got different roles. So anyways, that's something to think about. But I think that as long as we're thoughtful about trying to manage that potential risk, the benefits seem to be really clear.
One last thing I just wanted to throw out that we leveraged is the multidisciplinary team meetings that we have. I don't know if y'all do huddles in the morning and when you're inpatient rounding, and nursing is there, the attending's there, the residents there. And for our MPAT clinic, our maternal perinatal addiction treatment clinic, the addiction medicine team also joins. So that has really helped with driving roles and accountabilities too, because it's just like all said, okay, you're going to take care of this, you're going to take care of that. And nursing, do y'all know they're coming, or whatever's going on with the treatment plan? But that's also been really helpful.
Yeah, that's a great example, Emily. And I think also I've realized, particularly when people are uncomfortable with what we should be doing. So certainly with the launch of the B team, the fact that there was a team there to kind of back up, to support. The first few times I prescribed buprenorphine, actually still, if I were to prescribe buprenorphine, I'm like reaching out to Blair, checking with others, like that. It's really helpful. And I think the other example where we saw this was in COVID, in the early days in COVID, and having a team-based approach. And similar to what you said, we huddled every morning on all of our patients. And I think it just helped create that sense of like, it empowers you to feel more confident in doing things that otherwise you're like, gosh, I don't know. You know, I went to this talk, I support, I want to start buprenorphine, but like, I'm not ready to take that leap. But having that team around you really helps.
It takes the pressure off.
Exactly. Yeah. And, you know, for the nurse, knowing that the nurse has done it before, I certainly, like, when first time was like, the nurse, like, oh yeah, I know the protocol, this, you know, I did this with a patient.
We have a patient coming in on Monday delivering on methadone and scheduled induction. She's also Hep C. Her IV access is terribly, I mean, we're having to consult anesthesia on that. And like, again, the labor team is like, we need anesthesia. We can't do this. And so nursing needs to be ready for that access too. And we're probably going to have, we can't do peripheral access. So that's just another example of like needing, your team needs to be there, and it does take some of the pressure off when we can plan for that.
Well, wonderful. Let me just do a quick time check with Andrea here. Do you want to keep the conversation going a little bit longer?
I do, because I feel like we're getting these pearls, is what Ada specifically asked for, of wisdom, which I will say wisdom comes from things that you've learned you've done well and things you've learned you could do better. And if the group has any more of that, times it kind of didn't work out or moments where it surprisingly did. And Emily, I have to, that really great advice with incorporating huddles and communication and sort of the work that comes from that. So yeah, that's to anybody.
One of the things we're doing at JPS is we've done kind of a rollout educational series about the shout stuff and about starting bupe in the hospital to the physician-led services, OB, internists, family medicine. And we just rolled out, we have a nursing grand rounds educational seminar series, and we did that with them. And then we realized we need a nurse champion. And some of her insights were, this is great for as like an overview, But as we start to roll out kind of an order set linked with cows and buprenorphine specifically, that's when you should do more unit-specific educational approaches to each, either, tower, floor on the tower, or to the ICU, over to OB. And so that was one of the insights that came out of our encompassing and incorporating our nurse champion into the team. So there's kind of a two-tier approach, big overview, hey, this is what to look out for. And then once we develop the model, go deliver it to each unit, and perhaps in these huddles that I know that at least our nursing colleagues are doing. So
I actually think that's an important point, and similar to what I was trying to express, but I think you nicely laid out, which is even if you're on board, even if you're educated, even if you're like on the team, like on the B team, you actually want that just in time support. And so having somebody identified that's really close, like on that floor, or even just on that tiger text or whatever it might be, but the just in time is really important to getting that activation energy in the team. So I think that's really a great point. It's like ideally every unit, every nurse knows who's my buddy, like who's the person that I go to ask them right here. And it can't be, the answer can't be like contact Rich Botner in Austin, right? Like it's got to be the person on the 5th floor at wherever. So.
Yeah, absolutely. And just to share a quick story, reflecting on what Chris just said and Andrea had said, in terms of sharing a time that maybe things didn't go as well as we had hoped, and a nurse champion kind of fixed it. When we first started doing this work quite a while ago, we had initiated buprenorphine for a patient on a nursing unit that had not done it before. So other nursing units had, this nursing unit had not. And that evening, the patient had a syncopal event and fell. And of course, in the nursing world, a fall is a very big deal for all of us, but in particular for nurses. And so the talk on the unit was, this was the buprenorphine's fault. We don't ever want to have buprenorphine on this unit again. And as you can tell, I pride myself on interprofessional care and having relationships with all of our different disciplines, including nurses. They did not want to tell me that, partly because I was, our sort of major champion for the work, but also because I wasn't a nurse. So I heard about this through our nursing champion, who they did feel comfortable talking about this with. And then we sort of had a quick case conference at their huddle. And, when we started teasing the case out, of course, everyone recognized, no, this wasn't the buprenorphine. There were 101 other reasons that this patient had a syncopal event. And so people felt much more comfortable after it. But had it not been for our nursing champion, that would have probably festered for a while before I heard about it. And of course, you can imagine all the damage that can happen in, a few days' time of unmitigated discussion, right?
That's a great example there, and a great reminder of the importance of the champions and the ambassadors. Rich, we're coming up on the hour. I wonder if you might summarize some of the key points we've learned from our conversation today.
This might actually be really hard because there was a lot of really good discussion here. I think, one of the main things that I heard was nurses are awesome and critical members of our care teams, in particular for hospitalized patients with SUD, that we should empower nurses, that we should identify ways to ensure that nurses have the knowledge that they need. So a lot of this is about education and awareness. And then by sort of empowerment and elevation of the nurse's role in this, both sort of nurses at the bedside and thinking about ways that we can do that by having nursing champions, but then also by engaging sort of our executive stakeholders and ensuring that they understand that there's a sort of administrative benefit, if you will, to helping patients with SUD during hospitalization. And I think through the many stories that we heard, recognizing that it is certainly possible to empower nurses in this role. So I hope that was a decent summary. There was a lot of really good pearls that came out of this.
That was great. And Ada, thank you for prompting such a valuable conversation about this kind of care delivery and this kind of team integration. Thank you all so much for showing up to this space to have this conversation with us today. Thank you, Chris, for the didactics. And thank you, Ada, for giving us quite a lot to think about. We hope to see you at our next session next month. Everyone, have a wonderful rest of your Thursday. We'll see you soon. Bye-bye.
Thanks all. Bye.